All right, good afternoon, everybody. Well, welcome to our 32nd annual biomedical seminar series. Dr. Andra Basu, Vice President and Dean, esteemed faculty members, staff, guests, visitors, and especially all the students that are here today. It's wonderful to see you all. As well, I'd like to acknowledge the presence of Dr. Lakshmi Atchison, who's here today, who started this lecture series 32 years ago. So it's been going along very successfully for quite a long time. And it's included the brightest and best of researchers in science, allied health professionals, and also medicine. So last year I did a survey and I asked the students what topic would they like to have presented in our next seminar. And they clamored for a presentation relating to forensics, ironically. And so we have before us an expert in the fields of forensic pathology and forensic neuropathology, amongst other many talents that you have. I'm confident that we are in for a very engaging presentation from our guest speaker, Dr. Michael Johnson, who's present here with us today, almost in an act of providence through a connection with Brianna Bocella, who actually got her major's degree in forensic biology with us a few years ago and is currently working in Dr. Johnson's group. Dr. Johnson's credentials are remarkably impressive. He received his bachelor's degree in biology and PhD in neuroscience at UCLA. He was subsequently awarded his MD from Northwestern University Feinberg School of Medicine, which is among the best of the best medical schools in the country. He completed a subspecialty training in anatomic and neuropathology at Johns Hopkins Hospital and subspecialty training in forensic pathology in the Office of the City Medical Examiner in Baltimore. Dr. Johnson had served as medical examiner in Commonwealth of Kentucky before joining the Lehigh Valley Physicians Health Network and the Forensic Pathology Associates, which is located in Allentown, who provide a number of forensic pathological services to central and eastern Pennsylvania. Currently, his primary role is to collaborate with death investigators in nearly 24 counties in Pennsylvania to determine the cause and manner of unexpected deaths. Despite a very busy schedule, Michael also gives generously of his time teaching and mentoring medical students at the Morsani College of Medicine at their Lehigh Valley Regional Campus. He also instructs resident physicians in support of Lehigh Valley graduate medical education programs with the Lehigh Valley Network of Hospitals. He also serves as an adjunct professor with Thomas Jefferson University and I guess Temple now, currently too, as well. His credentials, again, I said, are impressive, which include memberships in the College of American Pathologists, the National Association of Medical Examiners, the American Academy of Forensic Sciences, and is certified by the American Board of Pathology in forensic pathology, anatomic pathology, and neuropathology. As you can see from the introductory slide I have presented on the screens, the title of his talk, which I think is going to be very fascinating, is The Continuing Utility of Postmortem Examination in the 21st Century. So I'd like you to give Dr. Johnson a very hearty welcome for being here and spending time with us this afternoon. All right, the stage is yours. Look.
Thanks everyone for having me. Is my talk coming up on the screen here?
Yes.
Great, thank you. Hi, my name is Mike Johnson. I am a forensic pathologist. That's primarily what I do. I do work here in Pennsylvania now with H&O Lab Medicine. I'm going to talk a little bit about what I do and what a pathologist does and how understanding why people die is important. And I know it's a mixed audience, different backgrounds with various types of exposure to forensics and perhaps autopsies, knowing what they're about or having viewed them or at least having a concept of them. So I'm kind of coming at this from different perspectives, kind of from historical ideas about where medicine came from, then with some kind of case-based ideas about what I do, but mostly it's sort of advocating for what I do. because I do think it's important. It's sort of at the nexus of medicine, public health surveillance, and justice in terms of holding people accountable for crimes. It's a part of quality assurance for medicine. And it's really part of science and education as well. And then if we don't understand why people are dying, and if we don't have these examinations to be able to do and solve those, to do that procedure and solve those questions, then we're really not probably going to be able to advance beyond where we are right now. So that's kind of, in a nutshell, what I'm going to talk about. I don't have any financial disclosures to talk about here. I work for H&L Lab Medicine. We're part of Jefferson Health now. We are part of a big network, but we're based in Allentown. You heard about where I came from a little bit, but just to nuance it a little bit, I started off as an undergraduate studying biology. Biology, at least back in my day, was kind of a conduit for most people to sort of medical school or perhaps to biotech jobs. So those are kinds of things I was thinking about when I was a biology major. And then I got involved in research and undergraduate training, and I got exposure to all kinds of different aspects of biology, and I really became fascinated in neuroscience. Neuroscience was really my first interest, so I started doing research in that, and eventually went into a graduate program at UCLA where I earned my PhD and an interdepartmental program in neuroscience. During that training, I actually worked in the Department of Pathology. I'll tell you a little bit more about pathology in a moment, but because it was interdepartmental, my mentor was in the pathology department, and he was actually a neuropathologist, which is also what I am as well. So I really followed in kind of a footstep of the footsteps of one of my mentors to follow my interest in, brain, CNS development, and neurochemistry and other things like that. And then realized at some point that I wanted to take that into sort of a clinical interface, understanding how basic neuroscience research could interface with treating persons. A long time ago, we knew nothing about why people were sick and why they died. I mean, we had maybe religious ideas about that. Maybe we had, other kinds of, assumptions about why people live and die. But we didn't really know until we could do some investigation into that. So part of that was really understanding how the human being is formed and functions. Before we knew that, we had no idea how to approach that sort of understanding of disease. So and you can really go back to kind of the Greek period in the 3rd century BC, where there were attempts at dissecting persons after they died to understand their anatomy and to sort of use that to understand how people function. But what you'll see as we talk about today is there's been a constant back and forth to this. Dissecting people after they've died, there are lots of taboos and religious ideas about whether that's appropriate or not. So over history, we've sort of gotten into it. We've used it to sort of understand who we are and how we function. But then there's a constant wax and wane to social opinions about this, taboos, religious things. So even after this initial sort of interest in dissecting of human cadavers, there were other scientists who said, look, we don't really need to do that. Let's just think about it from another point of view and stop these dissections. And so back and forth it went over the centuries. The Romans started going back to some of this Greek information and realizing there was wealth in understanding the anatomy of people. And they were starting to use this in terms of understanding how to practice medicine. But then, politics happened. The burning of Alexandria and the destruction of all the things in the library there. All that information was sort of lost. It was there, but it wasn't in that unique repository as it had been. It was sort of passed down possibly through verbal information or small texts here and there. So it really had to be recapitulated after the Middle Ages to some degree. We started again in Italy to some degree in the 14th century, but then again there was pushback because of religious regions and things like that, which kind of pushed us into the 1700s and 1800s before, again, it was sort of reasonable to do this again. So here, there are paintings like this Rembrandt, where we've got Dutch physicians who are using this anatomy suite to teach other people that are going to be physicians about, how the body is constructed. But this was very, very early understanding. This was very kind of a regimented dissection methodology. There was never, at this stage, correlation with the actual health of the person. It was more about, the nuts and bolts of us. How are things connected? And then in the midst of all this, again, there were these reemergements of social taboos. And part of this was because there were concerns about where these remains were coming from. And as you can imagine, people were stealing bodies and digging up bodies from cemeteries and doing things that would not be appropriate in order to produce these cadavers for research. So laws came about and things like that. So we really had to go through the process of understanding why we want to do this, how it fits in our society, and what are the laws that allow us to do these things. And things like families' opinions and medical opinions and religious opinions and things like that. We really had to integrate all of that into understanding how we would use this. But the point is that this really was the foundation of our understanding of medicine. If we don't know how people are built and put together, we can't really understand what's breaking down when they get sick. Pathology is the study of disease, and I'm a pathologist, so that's what I do. I study disease. I make diagnoses. That is, I determine why people are sick. Once we have that diagnosis, then they can be treated. Before that, you don't really know. And in the old days, think about humors and other kinds of ideas that people had. They would bloodlet and say, oh, there's something wrong with you. We don't really know what it is, but maybe if we do a bunch of different random things, something might help. Knowing how people are built and knowing how disease happens, we can actually precisely sort of affect what's happening with that person. If it's an infection, we can treat that infection. If it's something they were born with, maybe we can treat that. If it's something if it's an injury, maybe we can treat that injury. But otherwise we're kind of in the dark. So this is what built our understanding of disease, and it was multiple people over multiple centuries in Europe, the Middle East, all kinds of different places. As you can see here, an Arabian physician started doing some autopsies in the Iberian Peninsula and tried to use this in terms of guiding medical practice. But again, there were some back and forths there. I think at some point he was arrested for the work he was doing, and then so it's not always been easy. But really, I think you can point to the 18th century with Giovanni Morgani, where at the end of his life, he produced a great work where he had correlation between what people's health were, what their symptoms were, what they were saying about their disease, and then after they died, their dissection and comparing those things. That's called clinical pathologic correlation. That's understanding why people were sick and how it was portrayed in their anatomy. That was a great text that really sort of started this idea of understanding why people are sick and why they're dying. And then as we started getting technology like the microscope, other pathologists came and started using that to say, not only can we look at the person grossly, but we can look under the microscope and understand what's happening in the cellular level. And that's people like Dr. Virchow, who is considered the father of modern pathology and microscopic pathology. And then it was a question of how this actually ended up in the medical profession itself. Remember, that's sort of research, science, academics doing things. But we really had to make, as a discipline or as a profession, a decision that we were going to involve these kinds of tests, dissections, but also other kinds of laboratory tests in our understanding of why people get sick. And really this developed over a number of periods of time, including as a result of all the world wars that we had. The idea is that now we needed to know more about the places that we were going, other countries that have other kinds of endemic illnesses, and we needed to be able to treat our soldiers as they were moved over here. We needed to learn how to treat different types of trauma that were caused by all the weapons that we were using. So really, through the establishment of the profession of medicine, but also expeditionary sort of forces in medicine, we realized that we needed to basically have a lab in a hospital. And that was kind of a new idea. In fact, Johns Hopkins, where I trained, was where there was the first clinical laboratory just before the 1900. So this is a recent idea that we don't just treat by looking at someone, listening to them, and touching them, but we also have to do things like collect fluids and tissues and other kinds of components of them to understand what's happening within their bodies. So that's basically pathology. I don't want to belabor it, but if we go through this, more and more hospitals built labs, and then as biochemists and chemists and all kinds of other research scientists came up with new concepts like monoclonal antibodies and polymerase chain reaction and next-gen sequencing and other things like that, the pathology labs scooped up that new technology and started using that in our diagnostic toolkit. So where has the postmortem examination been and all that? It's been there constantly, because remember, we learned what people are about through dissecting them. And then, Dr. Morgani sort of figured out how to correlate their symptoms with what was happening anatomically to them. But now we're doing more advanced medicine, and we're doing things to people. We're giving them surgeries. We're giving them new medications. We're trying all kinds of new interventions. So what that means is we need to know what we're doing to people. And part of that is understanding if they die with or without our treatments or because of our treatments or alongside our treatments, we want to know that we haven't caused harm and we want to know how we've helped the person. And some of that happens after they've died, unfortunately. We try to find out as much as we can about someone during their life to diagnose them and treat them, but unfortunately people die still without diagnoses and they still die even despite our interventions. And that postmortem examination allows us to understand more about what happened. And that's part of public health surveillance and making medicine more advanced into the future. So really, this gets back to pathology. What is it? It is these days, pathologists, what we do is we work with our laboratory scientists and with our physician colleagues. We're kind of in the middle. So we manage our laboratories where they do the complex testing. We talk to the other doctors to understand what's going on with the patient, and then we put all that together from both sides. That's that clinical pathology correlation. And then we can tell the treatment team, based on these lab tests we did, based on what you're telling me, based on these other tissue examinations we did, your patient has this, and we can help oncologists and other doctors treat that person better. That's what pathology is all about. And like I said, if we get to the point where the person dies before we figured all that out, sometimes that postmortem examination is the answer. Families want to know why their loved one died. The treating staff wants to know why that person died. And if we didn't know before they died, that's our only way of figuring that out. So what is an autopsy? Again, I didn't know my audience, so I didn't want to show a lot of grotesque photographs today, so I'm just going to describe things. But basically, it is an examination of someone after they died. So think about if you go to your doctor, you walk in to the office, oftentimes before you even see the doctor, you fill out some paperwork. What's going on with you? Here's your insurance, et cetera. And then you're taken back to the doctor's office, and the doctor or the physician's assistant or whoever sees you first would sort of talk to you, take a look at you, weigh you, measure you. You know, if there's pain or something, they might push on you or feel what's going on with you. And then the doctor would think about you and maybe do more tests or order interventions. It's similar to the postmortem examination. The difference is the person's not talking to me. We bring the person in, they're lying on a table. We do that same sort of physical examination. We look at them. What can we see on their skin? What are their attributes? Do they have anything with them? Sometimes we do cases where, you know, they're forensic cases. People come in, they're wearing clothing. We look in their pocket. Oh, there's a syringe here. Oh, there's drugs over here. You know, so what's on them? What's about their personal effects that tell us what's been going on with the person? That's called an external examination. Once we do that, then we go on to what's called an internal examination. We make a Y incision on the torso typically, so that we can expose the chest, abdomen, and pelvis. We look at all the parts inside. That's what's called grossing. That's what a pathologist does to examine a tissue. And that happens with people that have died, but it also happens with people that have had surgeries. So for instance, a woman that's had a hysterectomy, the uterus and tubes and ovaries comes out of the operating room and goes to pathology where we look at it. Sort of like what we would do with the whole person at an autopsy. That's called gross pathology. That's examining the organ and tissue, seeing if there's something obviously wrong with it. If there is, we can sample it in various ways to get more testing performed, to have more meaningful understanding. So that's the point of all this. Ultimately, microscopic testing, molecular testing, other kinds of biochemicals testing can be part of that. So it is a quality assurance, public health surveillance. It is an answer procedure. If you don't have answers, this is the way you get answers. So it is the ultimate diagnostic test. In medicine, that's called a gold standard. When there is no better way of finding something, that's the gold standard. So gold standard is the best way to understand why someone has died and the best way to understand what has gone wrong with someone that you couldn't figure out when they were alive. We've been doing these things throughout medicine as a profession, these procedures. And in fact, it was required back in the day prior to 1970. The Joint Commission on Accreditation is something that accredits hospitals that says you have a hospital that's safe to function. And part of that safety was surveillance. If people are dying in your hospital, the accreditation board wanted to know that you were figuring out why they died in your hospital to make sure that you're not, malpracticing, to figure out that you don't have some new infection that has infested your hospital, to make sure that, as we know, there are, quote, angels of death sometimes, people in hospitals that kill people. make sure that's not happening. So, before the 70s and the 1950s, 60s, if someone died in a hospital, about half the time there was an autopsy on that person to try to make sure that we're looking for those kinds of things. If you didn't die in a hospital, there were other persons that may have done an examination of you. Those people are called medical examiners or coroners. We'll talk about them a little bit more. And we'll do it right now. So how do we figure out what happened to someone when they die? Usually what happens if you die in a hospital of a natural disease, these days you've probably been seen for a couple of weeks and your medical doctors really kind of understand you. So oftentimes they may not need an autopsy to explain your death. They know, they've diagnosed you already. They knew you had cancer. Unfortunately, they could not cure your cancer and you died from cancer. So the cause of death is your cancer, and it's pretty straightforward. And the doctor can certify that on the way out and explain things to families so they understand why their loved one died. On the other hand, if you did not die in a hospital, then maybe it was completely unattended. Maybe you're found dead in a ditch. Maybe you're found in the woods. Or maybe you're just found dead at home in your bed. There may or may not be information about you to understand why you died. And that's where an actual investigator must become involved. In Pennsylvania, usually that's an elected official called a coroner. But in some states, it's a person called a medical examiner. But they are officials that decide how to investigate your death. And the part in blue up there is basically saying, wherever you live in the United States, it's probably very, very different. If you live in Connecticut, they do something that way. If you live in California, they do it a different way. So there is no homogeneous way that death investigation is done in the United States, which, as you can imagine, could lead to problems. It could lead to problems in terms of who's doing it, their level of education. It could lead to problems about whether or not it's funded well by the local governments. It could lead to problems like which population is getting surveyed, which brings up ideas about socioeconomics, racism, other kinds of things. There's all kinds of complexities in this around the United States. So there is no one way that death investigation is done, and that's why when we talk about where death data comes from, we have to take that into consideration. There are about 2,300 death investigation jurisdictions in the United States. About half of those populations are served by what's called a medical examiner office. A medical examiner is a place where the official is a doctor. If not, then they're probably not a doctor. There are only about 750 to 850 persons like me in the United States that are involved in helping understand why people die through autopsies. That's a forensic pathologist. So there's not very many of us to go around. And a lot of people die in the United States every year. So who decides if an autopsy is undertaken? If you die in the hospital and it's a natural death, then it's up to your family. If your family has questions, they would ask the team, I would like an autopsy to understand what happened to my grandfather. And then they could sign a consent for autopsy, and that's how that would proceed. If you die outside of a hospital, it's those death investigator officials that I told you about. It would be a medical examiner or a coroner who would decide based on their algorithm who gets an autopsy and who doesn't. And they have full authority to order that because they're technically investigating. And then there's people in between, what are called private autopsies. We'll talk about this later, but part of what I'm talking about today is that we're doing fewer autopsies than ever, which could be a problem. I think it's a problem. I'll leave it to you guys to decide if you agree with me. But we're doing fewer and fewer of these investigations, and yet we have a larger population, meaning more people are dying every year. So what does that mean to our public health data? That's a good question we'll talk about. But it also leaves people kind of in the lurch. If you died at a hospital and the hospital doesn't perform autopsies or decides not to perform an autopsy for you, and the medical examiner or the coroner doesn't take jurisdiction to perform an autopsy, it's kind of up to the family to decide how they're going to get an autopsy, which means they have to go out and find somebody and pay somebody to do an autopsy. So there's perhaps some inadequacies and injustices out there because of the heterogeneity of death investigation. Briefly, what are the differences? Like I told you, a medical examiner is typically a doctor. A lot of times they are FP board certified doctors, forensic pathologists like myself, but not always. Coroners, on the other hand, usually are not. So in Pennsylvania, the only requirement to become a coroner for a county is that you live in that county and maybe you need a high school degree and you have to take a course. That's it. So there's no requirement for any kind of medical training to do death investigations in counties in Pennsylvania. Good or bad, we can talk. I won't take you through all this, but there's a complex way that the death investigators decide if they're going to do an autopsy. Basically, they have a budget, right? So everybody that has a budget can only do so many things. They can only do so many autopsies per year. They know this. So they have to be very judicious with their funds. Lots of people die in counties. In my county, about 8,000 people die a year. So they have to figure out how that's going to happen. How are they going to investigate some of those deaths? Are they going to investigate all of them? 8,000 people autopsies, that would cost taxpayers a lot of money. So they have to make complex decisions. So they start with circumstances. And they'll say, okay, is this an expected death? An expected death means somebody like I talked about that has cancer. You don't wish for them to die. You hope they live. But the fact is, if you have terminal cancer, likely you're going to die. So when you do die, that's not an unexpected death. So that they could just probably certify right away. Person had terminal cancer, they died, cause of death, cancer. On the other hand, they may not know enough about the person. So what they oftentimes will do is get on the phone and call the person's primary doctor and say, Mr. Johnson just died. Do you know Mr. Johnson? And the doctor would say, yes, that's my patient. And then the coroner or medical examiner could say, do you know why this person could have died? And maybe the doctor says, oh yes, he was very unhealthy and he had congestive heart failure. I'm really surprised he made it this long. He was really sick. In which case they might just sign it out based on that information, cause of death. On the other hand, the doctor might say, Mr. Johnson's totally healthy. This makes no sense to me. There's no reason why he would have died, in which case they need to investigate. And that's when it goes on to sort of not medically explained. And then it goes to the idea of a postmortem examination. So not every postmortem examination is equal. They have wide discretion, death investigators, to decide if they're going to go to the scene of death. If I died at my home, they could come to my house, search my house. If they found drugs in my house, they might think, okay, he's a drug user, he died from drugs, and then sign out the case that way without any other investigation. Right or wrong. I'm not telling you these are right or wrong things. I'm just saying this could happen. On the other hand, they could decide, he was in a motor vehicle accident. Let me just take a look at his body and see if he's obviously injured. And if they looked at me and said, oh my gosh, his head is just disfigured because of just terrible injuries, then maybe they might say blunt force trauma without doing any other kinds of investigation. On the other hand, if they look at the person's body, they can't figure out what's wrong with them, obviously, then they probably would order an autopsy. And in the middle there are other options too, like just performing toxicology. Toxicology is a test for drugs. Like I said before, there are a lot of assumptions in this. There's a lot of wide discretion, but there are plenty of people that die. They find a syringe, and the death investigators go, oh, obvious drug death, so I'm just going to draw some blood from their body, do a tox test. If the toxicology testing detects drugs, then I will call their death as a result of drugs. So very heterogeneous is what I'm trying to say. So what's the right number of autopsies? That's part of what I'm talking about today. It's a question. I don't have a great answer, but I think more than what we're doing is the answer. But that's my opinion. So just an idea of how this interplays in our society. This was an email from somebody at our hospital. So our hospital said someone died in our emergency department. The family wants an autopsy. They reported the death to the coroner. The coroner listened to the report and said, this is not our case. We think this person died from natural disease, so it's not our jurisdiction. So they basically turned it back over to the hospital and said, hey, you guys figure out why this person died. Which is very weird because this person just showed up to our emergency department. It's not like they were in our hospital for a long time. So someone that just comes in off the street from the emergency department means we really know not much about them. We would hope that the coroner would do the investigation, but they said no. But at the same time, they said, hey, by the way, the family could call and argue with us, and maybe we'll do it. So that's kind of how this process works. There's a tendency to not want to do the autopsy because of taxpayer monies. But then if the family makes enough noise and makes enough of an argument to say, look, the county needs to understand why my father died, then they will eventually sort of go, okay, fine, we'll do this investigation. Is that the right way to do it? I would argue not. It would be better to go based on criteria rather than being sort of harassed into doing something. But that is sometimes what happens. So people fall through the cracks here. Does the hospital do it? Well, the hospital doesn't want to do it. Should the coroner do it? Well, they don't want to do it either. So that could lead to that situation where the family has to do it on their own expense, which is a big ask. So let's talk about what's happened with postmortem examinations? Well, you can see right here, since the 70s, when the accreditation standards were you had to do a certain number of autopsies, back in the 70s, the hospitals had to do at least 20%, they had to do autopsies on at least 20% of deaths in their hospitals. And that was part of this public health surveillance to understand why people were dying in those hospitals. You can see it's trended down over the years. So as of this last time that CDC queried this, which is data from 2020, but this was reported in 2022 or 23, sorry. We were only doing doing autopsies on 7.4% of persons that died in the country across the board. So remember, in the old days, 40 to 50% of autopsies, 40 to 50% of deaths in hospitals were autopsied. And then there were all the other autopsies that happened outside of the hospital. Now you're seeing a very small amount of people queried in the United States. And you can see who gets an autopsy. Old people don't get very many autopsies anymore because, again, there's this assumption that they're old and they have disease, so why are we doing these exams? Right or wrong, I don't know, we can talk about it. And then you can also see a trend that goes along with that. People with disease are getting fewer autopsies, whereas people with external factors, that means things like trauma. So what's happened is there's been a shift in autopsies away from public health surveillance towards justice questions. So now we do autopsies on people that are shot, people that are stabbed, people that are motor vehicle accidents, people that die from drugs. But we've got this idea, I think, that we know everything about medicine and natural disease. And so we've kind of pushed away from the idea that this is public health surveillance, which I think is bad. So this is public data. You can get off the website, so I'm not releasing anything that's private. But this is from the county where I live. This is Lehigh County Coroner's Office data. This was from 2019. In 2019, there were 7,371 deaths, and the coroner performed 303 autopsies. So that's, they took jurisdiction of 13% of the deaths. So that means they investigated 13% of deaths in the county. The other ones they decided were natural or did not need an investigation. And then of those, they performed autopsies in 30% of them. So that there were 4% of deaths that were autopsied during that year in our county. Here's 2024. Basically, there were more deaths, 8,092, but there were only 130 autopsies. So they took fewer jurisdictions. They did half as many autopsies. That's the trend. There's multiple reasons why this could have happened, right? We can talk about that in a minute. But the point is we're just doing fewer autopsies than we ever have across the board. Why are they in decline? Well, these are some possible reasons. I don't know the answers, but you could argue, because we're so technologically advanced, we don't need autopsies anymore. We know everything. We figured it out before they died. I don't think that's true. We'll talk about it. It could be we know enough about our population that we don't need to do this public health surveillance anymore. That might have been a good argument, say, prior to 2019, 2020, when we had this pandemic where all of a sudden this huge disease came along and killed a bunch of people. So we don't obviously know what's going to happen from year to year. So we always need public health surveillance, I would argue. Then there are social factors, economic factors, and the government. So social factors, first of all, public perception of autopsy. As I told you, it's waxed and waned over the years, right, over the millennia, right? Some religions are against it. Some taboos, social taboos are against it. Understood. But what is the general perception? I'd say it's mixed. There's certainly religious objections and social taboos, but every day in my office, pretty much every day, every other day, every week at least, we are queried by families who are asking for autopsies. So there are certainly people out there that still are asking for autopsies, either for the hospitals to do it or to come and basically on their own dime pay for an autopsy because they have questions about their loved one. So it's mixed, but there's still a need in the population. What does the government think? Well, the government in 2019, yes, basically said we don't have to do autopsies anymore. So not only did the accreditation say hospitals are not required to do it, now they said, let me read the words here because it's kind of a gut punch a bit. They said that CMS regulation, this was 482.22D, was removed to reduce, quote, obsolete or excessively burdensome requirements that impede quality patient care. So they decided that autopsies were burdensome and obsolete, and that therefore they were somehow damaging patient care, which I think is an outrageous statement. But nevertheless, when CMS says something like this, CMS is the government's, the arm of government that decides how we're doing medicine, what things are paid for, how Medicare, Medicaid funds are distributed. It basically tells hospitals what they have to do, or what they should be doing. If the government comes out and says, hey, we don't need to do autopsies anymore, that basically gives hospitals the perfect opportunity to say, oh, well, we're not going to do them anymore. We're going to stop building morgues. We're going to stop having a cooler to store bodies in. We're going to stop hiring pathologists to do autopsies. We'll save money. Everything will be cheaper for us. But then you've lost this capability. And so this happens. Just to take a step back to what I do, I work in Allentown. Much of what I do is forensic pathology, working for counties with the coroners. But we also do hospital autopsies for our network. We're now part of Jefferson. We're going to start by doing hospital autopsies for Jefferson Network hospitals. But we also do hospital autopsies for our competitor hospital, which is St. Luke's University Health Network. We do autopsies for them. We do autopsies for UPMC. We do autopsies for a lot of different hospitals who have over the years stopped doing autopsies themselves. So they've stopped having the capability to do them. But the good news is they're still willing to pay for that capability. So rather than doing them in their hospitals, at least they contract with us. So they come to us and we can do them on their behalf. So there are still some bright areas in this, but there are some hospitals out there, unfortunately, that should someone die in their hospital and the family says, we don't understand what happened. We think there was a therapeutic problem. We think we don't even know why this person, why we don't even understand what the disease was. We want an autopsy. Some hospitals would say, sorry, we don't do them. Good luck. Maybe they'll give them a phone number and say, hey, I heard about this place, Forensic Pathology Associates. Maybe give them a call. Maybe they'll do an autopsy for you, but you'll have to pay for it. So that's a huge, imagine having someone in your family just die and now you're being told, we're not going to give you any more answers. That's not going to be a great interaction between the hospital and family. And then to turn around and also say, oh, by the way, you're going to have to come up with funds to fund this additional exam. Could be a huge problem for families understanding what happened. And then let's say that person died of a new disease that would have been important for public health to know. Family can't afford it. Hospital won't do it. No one ever knows because the person's buried with a disease that we'll never find out about because no one did the autopsy. That's where we are. So approximately 40% of hospitals no longer have the staff and facilities to perform autopsies. They've stopped doing them and or relying on at least contractual arrangements like we have to do them. And so you get things like this. This is actually a FATCA for a coroner's office where a family member said, why was my loved one, why didn't they get an autopsy? We had questions and you didn't do it. And they have this long answer about how, it's taxpayer money and they have to do the right thing. They have to manage funds, but we figured we knew what happened. That's what happens sometimes. People don't get answers because of judgment calls like this. And this has made the news, right? During the COVID pandemic, partly because of COVID, but partly because of funding and partly because of the CMS changes and requirements for autopsy, there were people left with unexplained deaths in their families and they had no one who could answer questions for them. So they were out there trying to find anybody they could pay to do an autopsy on their behalf, which was a huge burden. Here's from the website at Yale School of Medicine, what gets lost when you don't do autopsies? Not just the cause of death. That's less information for scientists, less information for doctors, less information for trainees. I would add less information for the families, less information for public health. So there's a lot of problems there. So why are they in decline? Well, I told you it's probably social factors as part of this. Economics is a big part of it. The government not requiring it anymore is part of it. But there are these other ideas that we think we're doing everything well because it's 2025 and we have molecular testing and CT scans and MRIs and all these other things. We should be figuring everything out before someone died, right? Well, let's see. What do we think we know about death in the United States? This is why we think people die, right? Recently. So most people die from heart disease and cancer. There's people that die from accidents, that's unintentional injuries. People have strokes. Look, this was data from 2023. You can see still a large number of people are dying from COVID. So, the pandemic's over, but we're still putting COVID on a lot of death certificates. So COVID's still there, just so we know. Let's look at it in sort of a different form. If we look at a pie chart, there's the same kinds of diseases we talked about in the top 10, but there's also a big quadrant that says other. What does that mean? That's a good question. Probably we don't know what that means. Why do people die if it's not natural? Well, they're dying from either homicidal injuries or unintentional injuries, accidents. Unintentional injuries, 20 years ago, that was mostly motor vehicle collisions. In the last decade, unintentional injuries are mostly drug-related. So not only do we have the COVID pandemic, but we've had this drug pandemic, opioid pandemic going on for years now. So it's still an important part of what we do, understanding why people are dying and is it drug-related. Do we believe that data, though? Here's the problem. It looks good. I told you, though, that the death investigation process is very heterogeneous. So the way they do it in Connecticut is very different from California, which is very, very different from Pennsylvania. And at the end of the day, CDC puts all that data into one big pot and treats it the same way. We don't know if that data is comparable. And in fact, if you look at studies, there are multiple studies. Death certification is not very accurate. If we're lucky if it's 20 to 30% accurate, but some studies say up to 96% inaccuracies. Now that ranges from little things like spelling problems and just general things to huge problems like the cause of death is wrong. If you have cause of death wrong 20% of the time and you put that into a national database, then you've basically destroyed that database. It's almost worthless in terms of understanding what we know and what we don't know. And that's why it's so important to do this. And I'm sorry if you can't read all this, so I'll just mention some things from these. I just wanted to show you that I'm not making this up. These are some abstracts from publications over the years where they've looked at the utility of autopsy. Basically, they compared what we thought the person was dying from before they died and what we found out they died from after we did an autopsy, after their death. We compared the two. That's what they're saying as discrepancies or utility. Basically, this study back in 2004 said that there were major diagnostic errors in 31% of cases. So what that means is about a third of the time, the clinical team thought they knew what was going on, but then when we did the autopsy, we figured out actually they died from something a little bit different from what they thought. That was a major error. And I'm not talking about malpractice. I'm not trying to blame anybody. I'm just saying these are things we didn't know until we actually did the gold standard, which is looking at the autopsy. And you could say, well, 2004, that was 20 years ago. Medicine's gotten much better since then. Yes, it has. So let's go forward a little bit. Here's 2005, the next year. At least a third of death certificates are likely to be incorrect. 50% of autopsies produced findings that were surprising. That's important. Let's go a little bit further. Here's 2012. So this is intensive care units. Again, people that died in the ICU, what we thought they were dying from, and what they actually died from. And you can see of these 31 studies, which was nearly 6,000 autopsies, they found misdiagnoses from 5% to 100%. Basically saying 28% of autopsies found at least one misdiagnosis and 8% identifying a class 1 discrepancy. A class 1 discrepancy basically means the cause of death was entirely different. So 8% of the time it was something completely different. The good news is 92% of the time, the clinical team knew pretty much what was going on. So again, this is not about disparaging the doctors. The point is there's only so much we can know with certainty unless we do more invasive testing. So we're gonna miss some of this stuff. And it matters in terms of that health data. You add things up, 20% of the time here, 8% of the time there, reporting things wrong on the death certificate. Pretty soon that public health data becomes very kind of questionable. If we go into the future, let's go now to 2024. So this was a big meta-analysis of, again, about 6,000 autopsies among patients. And again, they found that the class 1, where the cause of death was completely missed, about 7% of the time, but major discrepancies in about 20% of the time. So really, when people ask me, what's the utility of autopsies? I say, like, about 1 in 5 persons that die, you don't really know everything about what happened to them, unless you did an autopsy. So that's 1 in 5, where it could be something important to the family. Maybe you didn't completely miss the boat in terms of the cause of their death, but there may have been other conditions that contributed to their decline, which matters. Because as we know, having been through COVID kills. SARS coronavirus 2 kills people, but some people it kills on its own. Some people it kills because they have underlying conditions that it sort of exacerbates. Those are kind of two different groups of people. And sometimes their underlying conditions, their other things, their other contributors are almost as important as knowing why their primary cause of death occurred. So just a couple reports very briefly. Again, I'm not disparaging anyone. This happens occasionally. A 60-year-old woman came to the hospital. She was having trouble breathing. When she came into the emergency room, her lips were swollen, her airway looked swollen. So they thought, oh my gosh, this lady's having a reaction, sort of an allergic reaction that's closing up her airway. So how they would treat that is they would try to stop that inflammatory reaction. They'd give steroids and other agents to try to stop that. And then they would probably protect the airway for a while. So they would intubate the person to try to make sure they could breathe for a while. So they did that, but she didn't get better. So she was in the hospital for a couple weeks after that, and she just never got better. The swelling kind of went down, but her respiratory distress kept getting worse and worse. And eventually she's in the ICU, and they're still talking about this anaphylactic reaction. And in fact, when she died, I spoke to the doctor in the ICU who was calling about the autopsy, because we always speak to everybody to know what's going on. And I said, what can we help you out with? And he said, yeah, this is really weird anaphylactic reaction. She just didn't recover. And then she just got this persistent respiratory distress. And whatever we did just didn't work. And we just don't understand what happened. Just a weird study. And we talked about other things. But then I did the autopsy, and I realized this lady had breast cancer. It was obvious right away. One of her breasts had a huge mass on it. And that was not something I talked about with the doctor. And then I noticed she has a port. She already has a subcutaneous treatment port in place. So she's already with an oncologist being treated for breast cancer. And then I did the autopsy, and basically she had widespread metastatic cancer. And the reason for her respiratory distress was that she had malignant effusions in her chest. And that was what was going on. So again, this is not about blaming anyone. I went back to the doctor and said, hey, you know this person has breast cancer, right? And he's like, oh yeah, she has breast cancer. She's already following with an oncologist. We're aware of this, but she hasn't yet started her chemotherapy because they just put the port in. And I said, well, I think she died from breast cancer. And he was like, what are you talking about? She had this anaphylactic reaction. And the problem with this is what's called tunnel vision. Sometimes people come in with a condition, they get on a diagnostic pathway, and then they're treating that, and they don't take a step back and go, oh, this woman has other problems going on. And I think that's one of the saving graces of an autopsy, is you can figure this stuff out. I don't think anything would have changed with this lady. Unfortunately, her cancer was so advanced. It's not like she died because we didn't treat her in those week or two. But it's still very embarrassing when someone dies in the hospital and you're thinking about something completely different. So what is the good thing about this? I can go back to the treatment team, tell them this. They get the feedback. They spread the word. That's called a morbidity conference or morbidity evaluation. So morbidity mortality conferences is something in medicine where we say, we missed something here. Let's not do this again. And then they go and we make changes into the future. Maybe next time they'll do additional imaging. Maybe next time they'll do additional testing. So the point is, this helped the next patient. It couldn't help this woman, but at least it will hopefully help the next patient. Same thing in this case. This is actually another case. So this guy was 7 years old. He had Parkinson's disease. He choked, basically. People with dementias can have dysphasias. So I think that's why this happened to him. He lost consciousness at home. He was resuscitated and made it to the hospital, but then he basically was brain dead. When people were resuscitated, a lot of times there's ischemia to the brain and they can never recover. So he died basically from choking, but he was still alive on life support. So during that process on life support, they had not yet called him brain dead. During that time, the family asked for an autopsy, but they also were approached by Gift of Life. Do you guys know Gift of Life? It's a donor organization for transplants to people. So Gift of Life contacted them and said, I'm sorry to hear about your grandfather or whatever, and can we, is there a possibility that you would want to donate something to help somebody else? And they agreed. So they agreed to donate the liver, the kidneys, and some soft tissues and some blood vessels and maybe bone. So that process happened before the autopsy. So when we did the autopsy, they had already done that part of it. The reason is because they need the person still to be on respiratory support, on life support, so that they can do the transplant to a living patient. So that's kind of what they were doing. And then we did the autopsy in the midst of this. When we did the autopsy, the first thing we noticed is that the person was still wearing underwear. The underwear was like saturated in blood. So this was an interesting query. Like, why is this person's underwear bloody? So we looked in the medical records, and it turns out he'd had hematuria, that's bleeding in the urine, that had never been evaluated prior to his sudden death at home. And in fact, he was supposed to see a urologist or something like that, but he didn't make it to that because he choked at home, unfortunately. So in the hurry to get, consent for organ transplants to help other people, there was not the possibility to completely work this person up. So they took the organs, they went off to start the process of transplanting them. Then we did the autopsy and we realized this person had a large bladder cancer. So that's very, very bad in terms of transplanting organs from someone with cancer to someone else who's now going to be immunosuppressed. So basically, we were able to intervene and say, look, hey, this person has this didn't have metastatic, but this person has a locally invasive cancer. Probably don't want to transplant those kidneys because cancer can spread up through the ureters and other things to the kidneys. We don't want to give that person the risk of cancer. And they had a long conversation, and they actually still transplanted the liver, but they did not transplant the kidneys. So the point is, this not only helps understand what happens with people, but in this case, it actually steered what would happen to a living person or living persons, because that could have been at least 3 different people, 2 kidneys and 1 liver to 3 different people. So it's important. This is the cancer. This was a urothelial carcinoma that was growing into the muscle of the bladder. So what's the point of all this? It's important that we don't miss things. It tells us how we're doing in medicine. It tells us what we need to do in medicine. It helps treat living patients. Why are we making errors? CDC tells us how to do death investigation. Other people do as well, but the CDC says we need to do this well, and we need to be sure that we do the consenting or the certification correctly. But what it doesn't do is enforce the fact that really we need medical personnel making these decisions and not non-medical personnel. So again, I work with lots of coroners. I'm not disparaging that group of persons, especially since we consult with them and provide them medical opinions. But if there are death investigators out there making decisions on their own without good medical consultation, then they're basically kind of rolling the dice and just putting what they think might have happened on a death certificate, which could be a huge problem. So that's one thing I would say. We need to have more sort of medical involvement, because this is what a death certificate should look like. It's a complex idea of medical care and understanding how diseases progress. This is someone that had atherosclerotic coronary artery disease. That's coronary disease where the vessels are narrowed. As a result, they had a plaque rupture resulting in a thrombus, which blocked the coronary vessel. As a result of that, they had a myocardial infarction, which is a heart attack. And as a result of that, the heart ruptured and they actually bled. And these are complex terms that basically medical personnel would know, but not necessarily other non-medical personnel. So you can imagine who's filling out all these lines on death certificates if they're not medically trained. They're doing kind of whatever they think they can do to the best of their ability, but it may not be very good. The CDC supports broad discretion, but it doesn't really follow science too much, which is kind of scary. Because we need medical training. And I know we're getting towards the end here, so I'm jumping through this a bit so I can get to the points of things. The other thing is, what can we do? Well, we can add new technologies, and there's a new idea called virtual autopsy. This is an interesting idea. It's not really what's in the term, though. It's not an autopsy. What it is an unenhanced or non-contrast enhanced CT scan. So it's useful. CTs are good for seeing like skeletal trauma and some other things, but they're not so good for seeing a lot of the things that we find at autopsy. So I would say, if you've heard of this term, be wary of it. It's a thing, it's a capability, it's a tool, but it does not replace the kind of investigations that I'm talking about. And this is based in science. It does help improve. If you have no information, it helps improve that, gives you some information. But if you're comparing it to an autopsy, it's basically very generally insensitive, so not able to find things like rib fractures even, small blood collections in the body, structural problems with the heart, which is a lot of reasons why people die, including cardiomyopathies and valvular problems and things like that. It's not very good at soft tissue diagnoses. It can't diagnose a pulmonary embolism really well, which is when a blood clot goes to the lungs. So these are common reasons why people die suddenly, and the CT scans just can't really do that very well. So what does all this mean? Just to get to my point, which was the title of this. What is the utility of the postmortem examination in the 21st century? First of all, it's still useful. This idea that it's obsolete based on CMS, I just completely disagree with. It's wrong. The data shows that. If we don't do autopsies, we're going to miss the cause of death at least 6 to 8 to 10% of the time. And we're going to miss important things in 1 in 5 persons. And that's just people we really know about. People that are outside the hospitals that we know nothing about, we're probably going to completely miss why they died. We have no idea why they died unless we investigate it. So we need to have autopsies. And that has not changed despite our new technologies. We have new CTs, we have new MRIs. Going over the years since the 1970s to the 2025, every study shows very similarly. About 20% of the time we miss things, major things, if we don't do autopsies. So we need to be doing that. Post-mortem imaging is part of it, but a virtual autopsy can't make up the slack. We can use it as a tool. It's powerful, it's interesting, it's sexy in a sense because it's non-invasive and we can do this with fancy machinery and things like that, but it's not going to replace the actual tissue diagnosis because that is what we can do that other modalities can't do. And that is actually sample tissues to look under the microscope, sample tissues for lab testing, sample fluids for lab testing. Remember, all the things that we can do in these complex laboratories that pathologists made, we can only do that if we can actually touch the person, sample fluids and tissues from them, and understand if their anatomy is right. So I think it's still very, very important. And the only way we're going to move beyond what we currently do into things like more molecular testing is if we are assured of the data that we have. If the data set that we're looking at in the population is wrong because the data is bad, we're not going to know how to spend the resources we have to do things like complex molecular testing on people. People that have occult diseases like, channelopathies in their heart that they inherited, or seizure disorders that are due to complex gene abnormalities and things like that. We can't get to those people and try to help them without first understanding what's happening with the rest of the population. So I would say it's still useful, it's still important, it's important for public health, it's important for families. And so I advocate that we still do them. And that's my point of view. So thank you very much for your time. I appreciate it. Yes.
I had a question in the migration to justice issues. Oh, sorry. That's all right. I usually don't need that, but okay, thank you. I just won't scream now. You said that that they don't do examinations with the elderly. They're old. We know that they have diseases. What is the explanation for doing an autopsy in a gunshot victim? I mean, it's pretty clear, what caused that death in a knife attack, right? So the logic doesn't follow when we have what would appear to be a clear cause of death, unless your industry's falling into like the CSI, like where are we going to take this information type thing. So I'm really interested in how it explains one population but not another.
Right.
And I'm just going to also, I'll leave it at there.
Okay, yeah, great question. So again, this all involves people again, right? So the decision-making, logic is part of it. I wish we could all be logical, but it's not always logical. Justice is driven primarily by district attorneys and law enforcement, and they have their own sort of leverage in counties that it's different from the coroners. So a lot of times, if it's a crime, there is a tendency to do the autopsy as a matter of supporting that criminal investigation, even if we know the cause of death. So you could argue that let's say someone shot with a gun and it went through them. There's no evidence to collect. There's no bullet to collect because it went through them. You could argue, why are we doing the autopsy? We know they were shot through. And the answer is just kind of almost because it's needed for the investigation. There are cases, honestly, where someone was witnessed in public being stabbed. There was a case, it's an interesting case from years ago, but it happened in New York City. It was in a Orthodox Jewish population. This Orthodox Jewish gentleman was stabbed in public in front of a bunch of people. It was witnessed. And long story short, the person was not convicted because they did not do an autopsy. And that's just the court system. For whatever reason, the defense attorney said, we don't know that he died from being stabbed. Yeah, we saw him being stabbed, but how do we know he didn't die from something else? And if you can get that sort of, what is that called? The reasonable doubt. I'm sorry, I couldn't think of words for a second. If you can get reasonable doubt in the jury's mind, then you can destroy the case. So usually district attorneys, if it's a crime, even drug delivery resulting in death, they will err on the side of doing autopsies for the justice reasons. And that's why we've seen that trend away from natural disease towards external things, unfortunately. There's no such advocate for the natural side, because there's, other than the public health departments, like the departments of health, but they have their own stuff going on. And usually they're thinking about living persons and getting people vaccinated, making sure kids are fed and things like that, which is important stuff. So there's just only so many advocates for doing the autopsies for the natural disease processes.
Okay, and a quick follow-up to that question. In the naturals, if you identify that they have been mistreating existing conditions that are in the hospital, is part of this self-preservation, because you're talking major malpractice situations if in fact you are uncovering that 30% of them are being treated incorrectly.
Right. And I don't know that 30% is a good number across the board, but there's differences in places, right? So, but yes, I agree with you. It is of advantage to the medical system that we know if things are happening in our hospitals. There's a whole industry about quality assurance in medicine, and that is, root sum analysis of things, trying to figure out what's causing little processes along the way. Some of that's for efficiency's sake, some of that's for cost analysis, but certainly to make sure we're not harming patients. So there should be monies there for quality assurance. There's also monies there, unfortunately, on the civil side for litigation if someone has been malpracticed against. So that's where some of that comes up in the form of private autopsies. Sometimes families are kind of stuck. They think something's happened and they're asking for an autopsy because they think there's been malpractice. And so it does happen. It's not widespread, but it does happen. And that's part of the reason we want to make sure, from the hospital point of view, we want to make sure if we have 1,000 doctors working in our hospital, we don't want 2 or 3 bad doctors in there. We want to know that they're making mistakes to get rid of those 2 or 3 doctors so that the other 997 are doing great. So it is in everyone's best interest, the patients, the families, the medical system. Yes?
You mentioned that in the 50s and 60s, 20% that you had to have a lot of these autopsies, and there was a product of getting accredited, right? Those of us who teach here, we have teacher evaluations every semester as part of the way that the school gets accredited, right? You need to do assessment to find out what's going on. It seems very close to a conflict of interest for a hospital who's getting assessed by means of an autopsy not to have autopsies.
Right. And I agree with you completely. The issue, again, is the carrot and the stick, right? That's always the situation. So back in the 70s, when they said you had to do 20% of autopsies, there were also federal funds that came through training programs that supported that. And so not only did the mandate go away, but the money went away too. So I get it from the hospital's point of view as well. If they can't afford to do it, and they think they have to spend money elsewhere for the sake of patient safety, they will prioritize things differently. So there really needs to be not only the mandate, but also the funds to make sure that it's done from a public health point of view, to make sure that it's not just a matter of that. That's the same thing with everything else, right? When we're evaluating or review, there has to be a reason why we're doing it, but there also has to be some financial support for it. Otherwise, it won't happen.
Yes, I have a question.
Yes.
Oh, thank you for a beautiful presentation.
Thank you.
I have a question about in the United States, there are multiple organ donors who would like to donate their organs soon after their death. The timing is very crucial to remove the organs. And which one comes first, autopsy or removal of the organs? They both need it. And how crucial is that to remove the organs right away to save the other lives,
right,
rather than taking the autopsy? What is your take on that?
Right. So definitely. So I have a kidney transplant. So I think that we should get organs to people that need them. It's not just me, but our whole industry does believe that the organ donor organizations should have rapid access to donors. So we would not want the autopsies to get in the middle of that. There are times when justice steps in and says we can't do organ harvesting on this person because there's some investigation. So there's some areas where there's decisions made. But I would say we want to err on the side of making sure that organs and tissues go to people that need them. But we also have to have the right process in place so that if we find things after the fact, we don't harm people giving those organs as well. So typically what happens is if it's alive, if it's an organ that's being transplanted to a living person, the organ donation process happens before the autopsy. And we understand that. We see people after they've had the organs removed all the time, so we can work around that. And there's also communication between us and the organ donation facility because they do other tests that help us know what the health of those organs that are absent was. So we work with them. On the other hand, sometimes they do post-autopsy harvesting as well. Harvesting is a weird term, procurement, let's say. Sometimes they'll use skin, soft tissues, and long bones to help people, that have burns and need skin grafts or have other kinds of sort of membranes made that are used in surgery and things like that. They'll use bone, soft tissues, and other parts for that, and they can do that after the autopsy. So we coordinate with our clients who coordinate with the Gift of Life donors, the organ donation, which is Gift of Life, or CORE, which is out west. We coordinate closely with them. But I definitely want to make sure that if a person needs an organ and the person can give them that organ, that happens first. Sure.
Hi, so my question was similar to that. I had two questions about, if like the scenario that you gave, being as though like that person had a disease, they had cancer, and they were going to transplant that organ to the living person. Is it safe to say that like they could just look at the chart of how healthy a person is before they do that? Because if that part comes after you guys just do the autopsy, isn't that like a higher chance of giving somebody a disease that they never had before?
Definitely. And that's what I was kind of talking about with the process. Like I support these donation organizations. And again, I've benefited from it, and I want to make sure someone else can benefit from it. But at the same time, from a medical point of view, I want to make sure it's done right because we don't want to harm people either. So occasionally, we're in such a hurry to get people the organs they need that it's possible things can be overlooked. And in this case that I told you about, they just didn't appreciate the extent of hematuria and what it might mean. So hematuria may be nothing or it may be something significant. So the idea was they made a judgment call. They said, yeah, this person has Parkinson's disease, is otherwise healthy except for this hematuria that was never evaluated. They're going to make a judgment call. And in fact, when I received my organ, there were judgment calls. They basically said, this person has this person has this, or might have this. Are you willing to take that risk for the hopes of having a functional organ? And so there is some risk taking in this, no doubt. So we want to try to minimize the risk so that we don't give people diseases that we don't want them to get, but we also want to not have the threshold so high that no one ever gets organs, because then everyone would die that needs an organ. So it's the art of medicine.
Right. And my second question was, it was also like in regards to a scenario that you gave, that if like an EMS is on the scene, ME is on the scene and they see like, a syringe next to a dead person, that they would just rule it out as like a drug overdose or something. Is that not like malpractice? Because what if that syringe was just there in the environment and like something else caused the death of that person?
Right. I agree. Malpractice is not quite the right term for that, but I would agree it's wrong. Just seeing somebody, and again, I don't want to get into a lot of controversy here, but we make judgments about people all the time, right or wrong. You look at somebody and based on what they look like, whether it's appropriate or not, we make decisions. We say, oh, that person looks poor, or that person looks healthy, that person doesn't look healthy, whatever. And so there's a tendency for that in humans, right? To roll up on a house that's, maybe it's cluttered and maybe there's people around that look like they're drug users. And to find a syringe, that's not proof that that person died from anything. But there's a tendency for people to jump to those conclusions. So I would argue that you should not be ruling a cause of death just based on finding something at the scene. You should at least do some other testing. I really think you need to do an autopsy because we need to give that person the benefit of the doubt that they're not just some drug user that died. Maybe they died, maybe there's someone else in their home that has diabetes and that's a diabetic syringe. That's the craziness with some of this stuff sometimes. There's huge jumps to judgment about what could have happened to somebody just based on a scene.
Okay, that's my last question.
Sure.
So I read somewhere that like people are currently dying of like the measles disease. Like what is the CDC doing like to try to help fund so that you guys can have money to be able to do these autopsies? Because you said that like even your competitor hospitals, they're not doing the autopsies there, but they're contacting you guys to do it. So wouldn't it like click that autopsies are pretty important for us to like fund?
Right.
You know what I'm saying?
I agree. But it's government, right? They make decisions about what's the priority for monies. I'm on your side. I would, if you and I went to see the governor, I would be right there with you saying, we need money for autopsies. But the governor has other ideas about what that money should be used for, and the federal government the same way. And so I agree with you. In terms of measles, the big thing we can do is get vaccinated and make sure we're not allowing other people to get infected. So
said that like COVID is still killing it, you know?
yeah,
How do we know that COVID is like the cause of death or measles is the cause of death if they're not coming?
exactly. You're exactly right. If we don't know, if we don't examine those people, I'm sure there are people that have died from measles and COVID that we don't know about because no one's ever investigated. You're exactly right. Sure.
On occasion, you might have a medical examiner do an autopsy and come up and decide on the cause of death, and then the family disagrees, and then there's another autopsy done by another medical examiner. What's the process to determine whose opinion or declaration is the actual correct one?
Yeah, that's called a second autopsy. So occasionally there are second or third autopsies. So I told you what an autopsy is. It's making incisions and taking everything out. When we take everything out, we disconnect everything and really sort of take everything apart. So the best opportunity to understand what someone's anatomy is during that first autopsy. Now, having said that, there have been cases where someone allegedly had an autopsy. The family doesn't agree with the report. They hire their own autopsy person to go and do an autopsy. They exhume the body or bring the body from the funeral home or whatever. They open the body bag up and look at them. They never even had an autopsy. So there are bad people out there that have faked autopsies before. So in that sense, the second autopsy was really the first autopsy, and it was informative. So crazy things do happen out there, but I would say most of the time, if someone like me has done an initial autopsy, the utility of a second and third autopsy, they're exceedingly diminishing returns after that. And then you get into the issue of partisan sort of ideas then, because then it's a matter of now you work for the family. And I'm not saying anything against the family, but if someone has been hired for the family to dispute the first autopsy, there's a tendency for them to maybe err on the side of the family. Family may or may not be right. Maybe the first autopsy is right. The family has questions which are reasonable, but the first autopsy was still right. And now the second autopsy pathologist is sort of siding with the family. That does happen sometimes in justice cases where someone's shot in the front in the first autopsy, but then the second autopsy says they were shot in the back.
Go to a jury or something?
Then it's a battle of who's right in the jury. Yes.
Well, how accurate would the second one be if the first one was never done and the organs are dead now? So
Right.
how accurate would that be?
Yeah, you're right. It depends on how long after they said they did the autopsy. But when I've done a second autopsy on someone from the 1970s. So they actually, someone was shot. They thought in the 70s through the chest, and it was a cold case where they were trying to figure out who shot this person. For whatever reason, in the 70s, they only did a chest autopsy. So they only looked in the chest, got the bullet out, and then stopped, and then buried the person. And then years later, when they were doing this cold investigation, some witness came forth and said, not only was he shot in the chest, but he was also shot in the back of the head, like assassin style or something. So the police went and looked at the autopsy report and said, oh, they never even looked at the head. Let's do another autopsy. So they went and exhumed the person from the 1970s, brought them to our hospital. We looked at them. The person looked like they died yesterday. So I don't know what they were doing in the 70s to embalm people, but they were doing it really well. I did the autopsy. He was not shot in the head. So this witness was wrong. But the point is, there are times when especially if you've done a partial autopsy, you could add information, even many years later. But if you've done a complete autopsy up front, probably the best autopsy was that first autopsy.
Any other questions?
Oh, hello. Yeah, we're going to bring the mic to you so we can hear.
Hi, how are you?
Hi.
My question is, how common is it for families when it comes to donating organs to help another person continue their life. How common is it for families to get kind of, in a sense, like confused instead of just donating the organs to help someone, instead of they're just donating their whole body for science purposes? Because I know I read this one case about this family that they were from Korea and their son wanted to go to college in LA. So they went to LA and he was there studying and everything, and he ended up having this whole dispute and physical fight with another student there, and he ended up, from just the damages and everything, he ended up being brain dead. And his family, they're from Korea, the language barrier, they flew to LA and everything like that. And they were just kind of hurdled with a bunch of people trying to ask them, like, oh, are you going to donate the organs and everything like that? And they were going to and everything, but then they ended up finding out from a nurse pulling them on the side that, do you know that they're asking you to donate his entire body for science purposes? Like, you're not going to have anyone to bury and everything like that. And she wasn't made aware of that whatsoever. And she was made understood that it was just the organs. And I just want to know, how common is that mistake happen to people, or how often do people get confused with that, and how intricate is it for people to know the difference of what they're going to sign on?
Yeah, it's a good question. I honestly don't know a number, but I suspect it's pretty uncommon. It's actually, I'm not directly involved in the body donation process as much, although Jefferson, that I'm part of, has that capability now, so I probably will know more about that into the future. But typically, the most common reason people are being approached is for transplant organs and tissues. So that's going to be gift of life or core or something like that. The process you described is not optimal. It sounds like a bad process. The first issue is there should be good communication. And if you're having communication difficulties because of translation, that's a big red flag there. So that to me says there was something problematic with that whole process, because it should not be easy for someone who speaks another language to give consent for things without having made sure that there was a translator there and it being completely documented. So there are shady people out there in all aspects of life. But I suspect, that's a terrible story, and I'm sorry for them. I suspect it doesn't happen very often, but I would just reinforce that there are people that need organs because they're dying out there. So that's a very important thing that we want to support. But at the same time, we don't want to trick somebody into donating their whole body. And I didn't mention this before, but when we do autopsies, we're not disfiguring them in a way that so they can't go to have a funeral and things like that. So we are very careful about what we're doing during an autopsy so that they're still able to go forth with their funeral plans and things like that. So typically there's a good conversation between whoever's involved, whether it's the organ donation organization and the person's going to be doing the autopsy, to make sure that everyone understands what we're doing. That's called informed consent. So this family you had did not have informed consent. They had consent, but it was obviously not informed in a way that was communicated correctly. And that's a problem. That's whether that's a crime or malpractice or whatever, that's for that jurisdiction to decide, but it sounds like it's more kind of a criminal activity to sort of trick someone into taking remains and donating in that way. So it's uncommon, I think.
Thank you.
Yes.
My question is really about when the autopsy is done, if the cause of death is undetermined, so they're not able to make a determination as to what really is the cause of death. I'm imagining that's pretty rare, but just sort of like digging into that sort of space, like how as a medical examiner do you approach those sort of cases? Like what other things should be happening, or what other science do we need, or do you see what I mean?
Yeah.
The unknown is what I'm interested in.
Right. The question is about undetermined causes of death. There is a time and a place for a cause of death being undetermined. That really means we can't figure it out. And it could be science, it could be lack of understanding of disease, and it should be very uncommon. So in our practice, it's much less than 5%. So we don't, but having said that, I'll get back to that in a minute. That's the cause of death. There's another thing called the manner of death, which is the circumstances of how the person died. It's pretty common for manners of death to be undetermined, because that's a situation like we don't know it's a suicide, we don't know it's a homicide, we don't know if it was an accident, we know the person was injured, but we're not sure of the circumstances. That's pretty common. Undetermined cause of death should be pretty uncommon, because we should be able to find a medical disease or a traumatic injury or something else to explain it. Now, having said that, there are occult diseases, things that we can't see. It's estimated that maybe 20% of sudden cardiac death is occult. So that means you could have an arrhythmia and die without having an obvious coronary obstruction or a problem with your heart or something like that. Now, we usually figure those out because we can find that those deaths clusters in families. So if we find a family where they have a history of multiple people in the family dying of sudden cardiac death, we can still put undetermined, but then put in an opinion saying, this sounds like a sudden cardiac death, and the family history suggests that, and maybe additional investigations needed. So at least we can tell their surviving family that they might need to go to a cardiologist and say, hey, a bunch of people in my family are dying, we don't know what's going on. Maybe it's time to think about like a pacer or a defibrillator or something like that. So the undetermined is there for a reason. It's not saying we give up. It's there to give them a next step. If it's a crime, the undetermined is, hey, you need more investigation. If it's medicine, it's undetermined, but we think something's happening. We usually give some idea about what we think's happening. And that leaves it to the family and the doctors to try to make sure that the living persons are surveyed so it doesn't happen again. But hopefully a small amount, if that makes sense. Yes?
Who can speak very much for that? Because I had a family member who like died last year, and still didn't find the cause. Like very curious. So how would they go about, ever trying to like even find something or give us some type of explanation as to how?
Yeah. First of all, I'm sorry about your loss. That's a very disheartening sort of situation. It's something we know about, and we can only imagine the pain the families go through when they don't have answers. But at the same time, we want to be reasonable in terms of not making up causes, right? There's a tendency sometimes to say, I don't know what it is, so I'll just say sudden arrhythmia. And sure, like that's an answer, but it's not based on any sort of finding. So I feel for the families that don't have answers, but at the same time, I don't want to give them a fake answer. It might give them some fake closure, but what I don't want them to know, what I don't want to do is give them an answer and then have other people harmed because they're not aware that there's unknown reasons of death in their family. So I would say in that situation, I don't want to get into specifics in front of everybody about your family member, but if there's any inkling it might be a natural disease, you want to tell your other family members, hey, we have a history of sort of unknown causes of death that might be natural in our family, might want to go get seen. If it's a criminal act, if you think it might be criminal or non-natural, that's something where it really needs to go back to the police and other investigators to look into. Does that make sense, or does that answer?
So, like, it was a deep day.
I'm sorry, say that again?
30 years old, so it was really confusing, like, oh, no, this is unexpected.
Yeah. Yeah, that's a very upsetting situation for such a young person to die at 30 years of age and not know. But that could be one of these occult sort of diseases we don't know about, like a sudden cardiac death or something like that. So that's where I would say to the family, I understand you're worried and not having an answer, but part of the answer of not knowing is that you have to be vigilant about your health. Other people that are having symptoms when they're young in your family might want to go to your doctor and say, hey, by the way, my cousin was 30 and she died suddenly. So maybe you need to make sure you take a good look at me because I'm having symptoms. Does that make sense? That's sometimes the best we can do. Not everything is answerable, but we want to do our best. And at the very least, we can, when something bad happens, like not having an answer, at least we can take that forward and try to help somebody else so it doesn't happen to them, if possible. No, I'm sorry, yes?
So you said that obviously that's right. If you have a sort of unexplained death outside of a hospital, like, for example, my husband's stepfather just didn't wake up one morning. I think the assumption was that he had a heart attack. My mother-in-law opted not to have an autopsy. But if she had wanted to, would that have then been privately funded? And what's the cost? Like, I don't know her reasons for choosing not to, but what is the cost of just deciding you want an autopsy that the hospital isn't funding?
Yeah. So if he died at home in bed, I assume the death investigation group, whether it's coroner or medical examiner, is involved. If it was Philadelphia, it might have been medical examiner.
Yeah, Florida.
Okay, Florida. So Florida is actually a mixed state. There are medical examiners and coroners in Florida. Kind of weird, but depending on who the death investigator was, it should have been reported to them because it was an unattended death. So what could have happened, it sounded like your mom said no, didn't want an autopsy. But if she had talked to the coroner or medical examiner and said, I want an autopsy, they may have done it for her. You know, they might have said, yeah, I agree. This is an unknown cause of death. He died in bed. We don't have an answer. Let's do an autopsy. And then the county, or they have districts in Florida, so the district might have paid for it as a medical examiner case. If the county or if the district said no, then it's possible if your father-in-law had been seen at a hospital recently, the hospital might have done a hospital autopsy. Like, for instance, let's say he had recently had a surgery and then he was at home only a week later and died at home. The hospital that did the surgery, you might be able to call them up and say, hey, my father-in-law had the surgery a week ago and now he's died at home. We don't understand what happened. And the hospital might actually say, yes, he's a patient of ours. Come back and we'll do a hospital autopsy on your behalf. That's an option. And then finally, it would be trying to find somebody to do an autopsy for you. I don't know what it costs in Florida, but it's several $1,000s out of pocket to pay for an autopsy. So it's not something, most of us can't just reach in our pocket and pull out several $1,000s and do an autopsy. So it's prohibitive to some people. And that's why I would say, reach out to those people. Reach out to the death investigator, reach out to the hospitals where your family members have been treated. And if there are questions, maybe they will do it for reasons that are important to them, like following up on the surgery or following up on deaths in their district.
I think that my mother-in-law just wanted to bring him back here and bury him and he didn't have offspring.
Okay.
So that it wasn't like the HNO
Right.
family history.
Right.
I think she just wanted to be done with it. But I, scientist, was more curious
Right.
about the animal.
Right. No, I've been in the same fact. I mean, my dad died. I went out to see him, and he was in Florida. So I flew down there, and they didn't, I talked to the emergency room doctor. He didn't really know what had happened. It was very, so that was the same question I had too. Should I do an autopsy to figure this out, or just be happy that my father didn't suffer? And so I just decided on the latter, and I didn't ask for an autopsy. But even knowing that an autopsy would be helpful. So it's a personal choice. I'm not saying everyone has to do an autopsy. And in my case, I knew enough about my dad's health that I knew he had reasons for dying, even if the emergency room doctor didn't know that. So it was enough. But sometimes it's a personal decision. Sometimes it's a public health decision. Sometimes it's a hospital decision. And depending on where you are in the country, it's very different kinds of conversations. So I think we do the best we can do. And I think she made the right decision in her case. And then hopefully we don't have to make the same decision every day. But when it's our time, we'll make the right decision for us. Thanks, everybody. That was a lot. I'm so happy to have questions. Thank you. Thank you. Thanks for having me.